and exchange knowledge between the orthopedic surgeons all over Egypt. Today, my talk is spine imbalance, which is covered mostly by the previous eminent two speakers, Professor Ahmed and Professor Talat Al-Hadidi, and I will focus a little bit on some spinopelvic parameters and the relation between the pelvis and the spine. And through the talk, I will highlight some clinical applications for the sagittal balance and spinopelvic parameters. The intending learning outcomes for this presentation is to define the sagittal balance and interpret the spinopelvic parameters and define how the sagittal balance will change with age and how to apply it during our clinical life. Allah subhanahu wa ta'ala created us to have horizontal gaze while we are walking, and by this way we have a special complex phenomena while we are standing, because we are walking on post lower limb, we are bipedal, and this depends on a lot of acts in the hip joints, in the knee joints, in the spine as well, and it is really complex phenomena. And as we heard from Professor Ahmed, that the sagittal profile of the human being starts early during childhood, and according to the current literature, they found that the cervical lordosis may be developed even intrauterine. But as usual, we hear that during the patient growing period, when he starts to sit down, the cervical lordosis start to develop, and when he starts to walk, the lumbar lordosis start to develop. We have a straight spine in the coronal, in the anteroposterior view. We have a straight spine, but in the sagittal profile, we have distinguished curves, as Professor Talat highlighted that. Regarding the spinal deformity, which can be anticipated during degenerative and adult we have 12% spinal deformity can be developed before the age of 50, and 35% after the age of 65. And the sagittal profile is a devastating deformity. If we have kyphosis brings kyphosis, and it will affect the health-related quality of life. So it is really affect the patient's quality of life. What is the meaning of balanced spine? Spine alignment is a static phenomena, but when we are speaking about balance, that means it is a dynamic phenomena. It is when it is balanced, that there is no extra effort or no electric potentials are created in the posterior erector muscles to maintain us upright and have horizontal gaze. And spine balance, because we have a special relation between the pelvis and the spine. And the pelvis, we have some pelvic parameters, and in the spine, we have spinal parameters, which will be discussed in the next slides. Stagnara in 1982 started to highlight that we have horizontal gaze and we have the lumbar lordosis, but we have different shapes of the lumbar lordosis. All of us have horizontal gaze, as we can see here in these diagrams, which are drawn by Stagnara. And if we look for these human beings, we will see that they have different kinds of dorsal kyphosis and different kinds of lumbar lordosis. So the human being has, each one of us has peculiar sagittal alignment during his standing and walking phenomena. And we'll start by the pelvic parameters, and the most important pelvic parameters, because the pelvis is the foundation of the spine, the pelvic incidence, which is actually a morphological parameters, and it is a fixed parameters. And the pelvic incidence is the angle which can be drawn between two lines, and these two lines, the middle of the sacral slope and the perpendicular line to the middle of the sacral slope, and another line which connect between the point of the sacral upper end plate of S1 and the femoral head. So the angle between these two lines, the line perpendicular to the sacral plate at its midpoint, and the line connecting the midpoint of the sacral plate to the femoral head, and the pelvic incidence normally around 50, and actually it is not a fixed number, and according to the current literature, it is a range, and it differs between one person and the other. And the importance of the pelvic incidence that it is a fixed for each one of the human being. Because some mathematical calculations, we can calculate the pelvic incidence by the sum of the pelvic tilt and sacral slope. What is the pelvic tilt? The pelvic tilt is the angle between the line joining the center of the femoral head to the midpoint of the sacral plateau and the vertical line. This vertical tilt angle is around from 10 to 20 in range, and of course it differs according to the person. Have high pelvic incidence, that means he has different sacral slope. Low pelvic incidence will have also different pelvic tilt and pelvic slope. The sacral slope is the angle between the superior plate of S1 and the horizontal line, and its range from 30 to 50 degrees. And the golden equation that the pelvic incidence equals the pelvic tilt and sacral slope is important to be known by the spine surgeons. And this is the pelvic parameters. And what other spinal parameters we need to know? The lumbar lordosis, which can be measured by the determine the cup angle between the upper end plate of L1 and the upper end plate of S2 by drawing the cup angle. This is the lumbar lordosis. The thoracic kyphosis, which can be measured from D2 to D12, lower end plate of D12. Why D2? Because most probably D1, dorsal 1, cannot be seen during harvesting the lateral thoracic X-rays, so we rely mainly on D2. And currently, or especially in deformity surgery, we divided the thoracic kyphosis to upper thoracic curve from D2 to D5 and lower thoracic curve from D5 to D12. And of course, the thoracic lordosis need to be measured. These are the spinal parameters, and there is a relation between the spinal parameters and the pelvic parameters, and this will be highlighted in the next slides. What is the gravity line? As Professor Talat and Dr. Ahmed as well stated, that if we draw a line from our ear to the femoral head to stay at the ankle down to the floor, this is the gravity line. But in the spine, we correlated the gravity line with the C7 plumb line. And C7 plumb line, which is the vertical line that is drawn from C7 and pass through the thoracolumbar junction, and it is related to the posterior border, posterior border of the S1 sacral vertebrae. Because the central sacral vertical line, this sagittal vertical line, is important to determine if the patient has positive sagittal balance, that means he is kyphotic, or negative sagittal balance, that means the sagittal vertical line is posterior to the sacrum, that means he has hyperlordosis. And the gravity line is changing with age. Some studies found that with aging, that the gravity line start to fall anterior to the femoral head. So we have changes in the spinopelvic parameters and the gravity line with aging process. As we said, the pelvic incidence and lumbar lordosis is important, and if the patient have, or if the person have low pelvic incidence, that means the sacral slope is small, and mainly this patient has flattened lordosis. If the patient have high pelvic incidence, that means he has capability to compensate more, and he has pronounced lordosis and has sacral slope as well. And this is why we have different lumbar lordosis and different shapes of the lumbar lordosis in our patients. And the lumbar lordosis, according to Schwab, Frank Schwab defines that the lumbar lordosis is the pelvic incidence plus or minus 10. Plus 10 when we have low pelvic incidence or when we require small pelvic incidence because the patient cannot compensate by his back. But when the patient has large pelvic incidence, that means we can use the pelvic incidence minus 10 as a definition for the lumbar lordosis. And it is of quite importance that to know that 2/3 of the lumbar lordosis present between L4-5 and 5S1. And the clinical application of this point that during spinal fusion, we need to have 2/3 of the lumbar lordosis between L4 and L5 levels. And this can be achieved by putting cage. We can put the cage that's quite anterior, and we can compress from posterior after doing vasectomies to create the maximal lordosis, which can be simulating the patient profile. What about the thoracic kyphosis? There is another formula that can describe the thoracic kyphosis in relation to the pelvic parameters as well. The thoracic kyphosis, defined by Lamartina from Italy in 2014, that thoracic kyphosis is pelvic incidence divided by R minus the lumbar lordosis. And according to their research, they found that the R is different between the population. When the people is less than 60 years old, it is 2.5, but when they are more than 60 years old, it is 5.4. So we have equation which can be define the thoracic kyphosis according to the pelvic incidence, and of course it is differ according to the patient age. This is a sagittal vertical axis which can be correlated to the gravity line, and it is important because it is a predictor to the symptomatic patient. If the patient sagittal vertical axis, which is C7 plumb line, is too much anterior from the posterior corner of S1 vertebrae, that means the patient has positive sagittal alignment and positive sagittal balance, and it will affect his quality of life, and this needs to be corrected. As we said, sagittal alignment and the sagittal is a static, but the patient, because we are dynamic, we are a mobile creature. So when the patient start to have positive sagittal alignment, we start to compensate. Of course, the compensation starts within the spine itself. As we can see here, this is an example of spondylolisthesis, and with the spondylolisthesis, we have local kyphosis. We have local kyphosis at this motion segment. And here, the spine starts to compensate by creating compensatory lordosis in the adjacent levels. Compensatory lordosis in the adjacent levels. But when the spine is stiff enough or there is marked degeneration in the adjacent levels as well, so the patient starts to compensate by retroversion of the pelvis and hyperextension of the hip. And even when this compensatory mechanism fail to compensate for the positive sagittal alignment, the patient start to bend and flex his knee to try to push the gravity line and the sagittal vertical axis posterior to be within the 5 centimeter away from the posterior corner of S1, which is more physiological for our standing and walking phenomena. And as we can see here in older age population, some of them can walk by putting the hand behind the spine and holding the hand together, and this help him to do hyperextension in the spine and in the hip as well, and flexing the knee. And if they cannot compensate by this phenomenon, some of them may have some walking aids, and this helps them to avoid falling down due to the kyphosis. All of these are compensatory mechanisms and can help the imbalanced spine to avoid falling down. The coronal imbalance is also one of the important area, and we can calculate the coronal imbalance by C7 plumb line drawn from up and the center sacral vertical line drawn from the center of the sacrum. And if the distance between these two more than 4 centimeters, that means we have coronal imbalance. And of course, coronal imbalance can be tolerated a little bit if we compare the coronal imbalance from the sagittal imbalance. Sagittal imbalance is much have negative effect to the quality of the life of the human being. This is how to measure, as we said, the pelvic parameters, the pelvic incidence, sacral slope, and pelvic tilt, and correlate it with the spine parameters, the thoracic kyphosis and the lumbar lordosis. And of course, we have special parameters for the cervical spine, which is beyond the the scope of this lecture. And sometimes we need to measure the global spinopelvic alignment. And the global spinopelvic alignment can be measured by T1 pelvic angle. And T1 pelvic angle is the angle between line drawn from the dorsal 1 vertebrae to the middle of the head of the femur and the other line drawn from the middle of the sacral plateau to the middle of the femur. And this T1 pelvic angle is correlated with the health-related quality of life according to the literature. And if it is more than 20 degrees, that means there is severe disability. And of course, it will be bigger if the patient has pelvic tilt, increase the pelvic tilt, and has vertical sacrum as well. And this will increase as well if the patient has kyphosis. So it is a measure for the global spinopelvic alignment and can be related to the quality of life as well. So how to apply this in our surgery? The goal of our surgery is to have balanced spine, because of the patient when he walks in a balance, he has no need to exert more effort by the back muscles, and by this means we have economical balance. So first of all, you need to measure the pelvic parameters, and you need to correlate it with the spine parameters, and you need to identify the patient type of lordosis according to Pierre Rossoli. And when you decided the patient have small pelvic incidence or high pelvic incidence, and where is really the apex of the lumbar lordosis, for example, if it is low lumbar lordosis, that means he has low sacral slope and low pelvic incidence. That means when you are fusing him and when you are fixing him, you are creating less lordosis in the rod, as we can see the rods which are pinned lower down according to the types of different types of lumbar lordosis according to Rossoli. So it is very important to identify your patient peculiar spinopelvic parameters, and it is very important to start to mimic the patient real parameters to avoid adjacent level pathology, as we heard one of the questions which were highlighted by Dr. Mohamed Abdelal. And this is one of the papers which are speaking about the importance of creating the lumbar lordosis, and it is also done by Pierre Rossoli and his team in 2017, and they studied 250 patients with adjacent segment disease. And here I'd like to highlight one point: adjacent segment pathology, that there is degeneration or degenerative cascade either in the facets or in the Boschan segment adjacent to fusion. And there are different pathologies. It can even come with some fractures, but this pathology becomes symptomatic. So Pierre Rothel and his colleague studied 250 patients with adjacent segment disease and degeneration, and they found that when you fail to achieve the proper lumbar lordosis, you can have up to 75% proximal junctional kyphosis. And if you really create identical spinopelvic parameters, you have incidence up to 13% to have proximal junctional kyphosis. And these points can support what is Professor Talat Al-Hadidi said, that it maybe has a iatrogenic element as well. Not only biomechanical aspects, but maybe has some iatrogenic. If you hit the facet capsule, if you have long rod hitting the facet capsule, if you destroy the tension band, if you destroy the interspinous ligaments in the proximal levels, if you not respect this tension band, you may create create proximal junctional kyphosis and create adjacent segment disease, even when you are restoring the proper biomechanics of your fused segments. So some colleagues, especially the European Spine Study Group, start to search more in the spinopelvic parameters and the spine data, which was published by Frank Schwab and the French colleagues. And the European Spine Study Group start to say that it is not certain figures, but we need to have a range, and this range, of course, differ from person to person. And they start to use the Pierre Rothel and the different types of spinopelvic parameters in the human being, and they come with the GAP score, which is a global alignment and proportion score, which is depend on when you are using this score to fuse your patient, you will achieve the best spinopelvic parameters for your patient. They start to speak about the relative pelvic version, the relative lumbar lordosis, the lordosis distribution, where is the maximum lordosis, where is the apex of the lordosis, where is the relative spinopelvic alignment, and the age factors should be considered as well. And this helps to avoid the adjacent segment disease by following this GAP score. And my take-home message is that the spinopelvic parameters really change with age, and it is very important to evaluate it to identify your peculiar patient-specific sagittal alignment, and it is mandatory to select the suitable surgical technique for your patient, age, and lifestyle to help him to have proper life during his life being. Thank you very much.
Thank you so much, our beloved Professor Dr. Mohamed Khattab, for your marvelous talk. Thank you so much, sir.
Thank you, Dr. Mohamed.
اساتذتنا استاذنا الدكتور جلال، استاذنا الدكتور طلعت بيه، دكتور اشرف بيه، حد ليه اي كومنت يا اساتذتنا؟ Any questions, sir?
دكتور طلعت اتفضل.
You are muted, دكتور طلعت.
دكتور طلعت بيه. اتفضل يا معالي الباشا.
أنا كنت بس عاوز أضيف إن how to calculate the amount of kyphosis you need to correct. إيه ال pre-op plan اللي المفروض تعملها as a surgeon عشان to regain the proper sagittal balance للعيان, to restore the balance, the gaze and everything. ولازم نبقى عارفين ان كل اوستيوتومي، نوع من الاوستيوتومي ليها amount of correction، بحيث لو انت محتاج 40 درجة correction for example، هتعمل كام PSO وهتعمل كام SPO. لو تسمح توضح لنا دي عشان برضو الزمايل يعرفوا لما الديفورميتي جالهم يعملوا ايه فيها؟
تمام. هو بالنسبه للاوستيوتوميز زي ما حضرتك تفضلت وقلت، انا لازم اقيس البلفيك انسيدنس الاول. اي عيان جاي لي عشان اعمل له عمليه لازم الايديال ان انت تعمل لونج فيلم جايب الهول سباين ستاندنج علشان نقدر نشوف العيان ده ساجيتالي الايند ولا لا. واكوردنج للميجرمنت اللي احنا زي ما قلناها البلفيك انسيدنس، اللامبر لوردوزس، دورثال كايفوزس، بنبدا نشوف العيان عنده الديفورميتي فين بالظبط، وبنبدا نبلان الفيوجن ليفلز بتاعتها. الفيوجن ليفلز بتختلف طبعا، سواء الديفورميتي دي في الساجيتال بروفايل في الكايفوزس، سواء الابر اند غالبا في الكايفوزس على حسب اللوكيشن بتاع الكايفوزس، وغالبا بنحتاج نجيب من دورسال 2 لحد الفقره اللي بتبقى بايسكتد من الساجيتال فيرتيكال اكسس من بوستيرلي. طيب هصلح قد ايه؟
الستيبل فيرتبرا يعني.
بالظبط. ممكن نبقى نهايلايت النقطه بتاعتها وير تو فيوز وين تو ستوب والكلام ده في ان شاء الله يعني حاجات ثانيه عن الكايفوزس ممكن. انما النقطه اللي حضرتك هايلايتد الاوستيوتومي بتاعتي، لو انا محتاج مثلا حاجه اصلح في رينج ال5 درجات، لو عملت حاجه زي البونتي اوستيوتومي او ايفن ببساطه فاسيتكتوميز وعملت ريليز كويس، انا ممكن اصلح على كل ليفل 5 ديجري. لو محتاج اكتر من كده ممكن اعملها على كذا ليفل وتبقى حاجه ريجولار وهارمونيوس، لان كتير قوي مننا ممكن يصلح الديفورميتي بديفورميتي عند ليفل تاني، وده ممكن يعمل بي جي كي. هو الايديال ان انت نشوف العيان الايبكس بتاعه فين المظبوط والانسيدنس بتاعه كان ايه، ونبدا نكريت هارمونيوس لوردوزس وهارمونيوس كايفوزس. لو انا محتاج اكتر من 5 ديجريز، مثلا هنقول حاجه زي مثلا 20 درجه 30 درجه زي ما حضرتك تفضلت واوضحت، هنا ساعتها ممكن نعمل حاجه زي البي اس او. كنت حضرتك حاطط دياجرام كويس قوي ليها، ان انا بعمل زي كلوزنج ويدج وبشيل البيديكل واعمل كلوزنج ويدج فروم بوستيريور، ودي ممكن تصلح لي فروم 15 ل 30 درجه. طب الدرجات دي بتعتمد على ايه؟ بتعتمد على القات بتاعي. انا ممكن البي اس او تبقى انفولفنج فقره واحده، وممكن البي اس او تبقى انفولفنج فقره وديسك فوقيها. طيب عاوز اكتر من كده ممكن اعمل في سي ار، ان انا اشيل فقره كامله وابدا امانيبيوليت الفرتبرال كولم بتاعي واصلح كتير جدا. فهو احنا عندنا different types of osteotomies، وفرانك شواب كان صنفهم الى 5 تايبس. بتبدا بالفاسيتكتوميز، وبعد الفاسيتكتوميز ممكن نعمل حاجات زي البونتي اوستيوتوميز، ان احنا بنشيل الفاسيتس والليجامنتم فلافم، وبنشيل جزء كمان من اللامينا، وبعد كده البي اس او، وبعد كده الفي سي ار، وبعد كده البي اس او نفسها اتقسمت لاكستندد بي اس او، والفي سي ار بقت بدل ما هي سنجل فيرتبرا بقت ممكن اعمل دبل ليفل او اكتر في سي ار كمان. ارجو ان الامور تكون وضحت كده يا دكتور طلعت، ولا حضرتك هتحب تضيف حاجه؟
لا يو ساتيسفايد كل البوينتس اللي انا عاوز اقولها. ميرسي.
تمام.
Any other comments, sir?
I would like to thank Professor Khattab for this very nice presentation. حقيقة شغل هندسة راقي جدا، ونشكره على مساهمته معنا في
شكرا يا دكتور جلال بيه.
شكرا يا دكتور خطاب.
هو حضراتكم اساتذتنا، يعني النهارده كان يوم قوي جدا ودسم جدا، وبدايه قويه جدا لكورس السباين. النهارده we meet the experts بوجود اساتذتنا استاذ دكتور جلال بيه، استاذ دكتور طلعت بيه، استاذ دكتور محمد بيه، واخونا الكبير الحبيب استاذ دكتور اشرف بيه اسماعيل. النهارده كان يوم قوي جدا، فنشكر حضراتكم على تواجد حضراتكم معانا. احسن بدايه لكورس السباين بصراحه، يعني يعزي الفضل فيه بعد الله سبحانه وتعالى لاخينا الكبير استاذ دكتور اشرف بيه اسماعيل، اللي هو بذل من جهده ووقته ان هو ينظم الكورس معانا. فاحنا بنشكر حضرتك دكتور اشرف بيه على التنظيم الرائع ده.
والله الف شكر يا دكتور محمد بيه، وده يعني طبعا شرفتنا فيه، وشرف لينا ان احنا الحقيقه نقدم حاجه للكليه اللي احنا اتعلمنا فيها يعني.
نشكر حضراتكم يا فندم، وميعادنا بكره ان شاء الله مع تكمله كورس السباين مع الدكتور بهاء بيه قرنه. هيتكلم على radiology of the spine. دكتور مدحت رفعت from Benha will speak about MRI of the spine. والدكتور وليد طلعت will speak about recent modalities in physiotherapy of low back pain. Thank you so much. وإن شاء الله نراكم بكرة 10 p.m. وبنفكركم بالانترناشونال سباين داي اللي بيضم نخبة عظيمة من الكونسلتنتس all over the world، وهيبقى أحسن ختام لكورس السباين إن شاء الله. إن شاء الله see you tomorrow at 10 p.m. ونشكر أساتذتنا الأفاضل على تشريفهم لنا في الكورس. شكرا جزيلا يا فندم وتصبحوا على
ألف شكر يا جماعة على